class was a 75.
Say that, okay, hang on. Say that again. Wait.
The average for
I need
Lundy's
to go
class was a
back.
75.
That was the average in Dr. Lundy's class?
Yeah. That's the
Yeah,
lowest average that I've seen this far since I've been in this school.
Most of us, we watched the recordings, we went to every class, we studied the review, and I still got the lowest grade of my life on this exam. Like, it's ridiculous.
Yeah, we shouldn't just be going through this. We have 2 other huge classes to study on a daily basis. We have lives, we have jobs, we have kids, and the community class is just overwhelming. Like,
And then it's only 3 exams, and we also have a HESIs. It's like,
exactly. Like,
for
we've
those of
gotten
us that
far
got a
in this
really low
program.
score.
Okay,
We're way too far in this program for this class to knock us down. Like, it's ridiculous.
This is my second time taking. This is my second time taking this class. I took Med Surg and Peds last term. I passed both of those classes with flying colors. This 2-credit class I thought should have been easier, but it's actually harder than the other classes, and it's still with this exam. Yeah, I got a better grade this term, but it was still hard.
okay.
And I believe the concept map that was given to us was not helpful at all. I don't know about anybody else, but for me, it did not help me at all.
And it says not inclusive. Like, why not all of our other classes, they give us concepts? Like, why does it have to be so? I just don't understand.
Britt.
First of all, we have not been taught how to do concept maps. I'm 49 and have no idea what the heck a concept map is. And honestly, with the studying I did, I would have been happier with a higher grade, but the content was, I mean, very difficult to understand.
I agree. Like, the concept map was only 2 pages. 2.
Well, now, what are you guys talking about? The what? The content
The
map?
study guide that community provided for us, it was only 2 pages and it was very broad. It didn't go in detail. It just say, know this, know this, know this.
It
And
was,
like as
the study guide was
teachers,
4.5.
I feel like we're not even being taught in class.
Okay. The study guide that I sent out was 4.5 pages.
I believe that, I don't know if others feel like this, but I think that having a paper book would be better than trying to navigate the book online. I don't know if that's just me or if others feel
Okay.
that way.
I completely
I
agree.
agree.
I agree. Online is too hard.
I have a paper book. I purchased it and it's still hard. So
Okay,
And then I did
well,
have one question. I had a question about one of the questions in particular, which was, I think was the worst one for me. Which a
excuse
lot
me
of
for
them
1
were pretty-
second. Could everybody please turn on their cameras? I want to see faces. Thanks. Everybody turn on their cameras. Isabel, Sarah, Leah, Courtney, please turn on your cameras. Okay. Mary Jo, Brandon, Erica, Morgan, please turn on your cameras. Mary Jo has problems with her camera. Okay. Erica? Okay, nobody's driving, correct?
No.
Is anybody driving?
I'm driving.
Okay, well,
I'm driving.
and I'm
okay,
about to be driving. I have to pick my kids up from school.
okay. Okay. Okay, keep going. Somebody was starting to say something before I asked for people. Erica, is there a reason why your camera's not on? Mary Jo, I've heard from you. Erica, I haven't heard from you. And Esperance, is there a reason your camera, please turn your camera on. Just for the beginning until I share my screen and then you can do what you want. Thank you. And before I forget, I've let some other people in, so if you're Dr. Lundy's student and you haven't signed in, please put your name in the chat. I would appreciate it. We're up to 45 students, so it's a big group. All right, so keep going. Somebody was talking about,
Yes, I was saying, a few of the questions came across, like I was saying before with the typos and stuff, but one question in particular, the question regarding the safe practices for a nurse when she's setting up, a visit at a home, it
Mhm.
was asking which was unsafe, but all of them that I saw listed, and I don't know if anyone else feels this way, but from what I recall in the review,
yeah,
everything that was listed there were things that they said not to do. The only one was like that was questionable. It was saying not to tell anyone due to what HR, I mean, due to what was it?
HIPAA, I think it was HIPAA privacy.
HIPAA regulations. And they told us that we needed to leave a schedule at the front desk to let the office know where you were going. So it was like every answer under there was answers that they told us were unsafe, but then they wanted us to pick what was the safest. So that was really confusing.
I believe that question was given back to you guys.
Okay.
And most of the questions were like that. There was this question that they were asking for the barrier for something, and for me the barrier is something that stops you from doing something, and then all the questions were right. So
Yeah, the
at that
barrier
point you were
question.
like, yeah. So
That
I
question
don't
was
know.
given back to you as well.
How about the question with the playground, with the rope and the hooks?
That one was just so difficult too. There were
That
two answers
question,
that
hang on, that question was,
Because in the
Teresa, hang on, that question was given back to you guys as well.
okay, cool.
Well,
Thank
how
you.
many questions were given back?
Then
Because if
basically
we
yeah,
had,
because
That's
in
what
that
I was
case,
gonna ask. How many questions were given back and we still failed the exam or close to fail?
yeah. So if you, yeah, because so many
Everybody
questions were
just
given
hang on a
back.
minute. Please don't yell at me. Okay, please don't.
I'm not yelling. I'm just
Please
kind of
don't raise your
frustrated that I
voices.
studied for nothing.
No, you didn't study for nothing. I can't give out that information, but the 3 questions you just mentioned were given back. Okay,
well, then that's scary that the exam scores were even lower than what we received.
well,
Oh my
we don't
goodness.
know
then
that.
That test was
Hang on
awful.
a second,
Sorry.
but you don't know that you got those questions wrong either. You could have gotten them right. And so, if 3 questions were given back, you could have gotten all those 3 right. Doesn't necessarily mean you got them wrong.
But it doesn't help if we all did terribly and we studied and it feels like it's all for nothing.
Okay,
Especially the people that are retaking the class. I'm one of the people that are retaking the class, and I don't feel like I should still be getting the same kind of scores if I'm studying the material provided to me.
Okay, and this was a new test for this term.
That's understandable, Dr. Marvel. That's understandable. But if I'm studying what was provided to me and then I get the test and it's nothing like what I went over, that's not helpful. It's
Okay,
not helpful.
I understand. I hear you.
Okay, thank you. I'm just gonna be quiet.
No, that's okay. I hear you. It was frustrating for a lot of students. We, I tell my students, I try and look at this as teamwork. I try and teach you the key concepts that you need to know, the key knowledge that you need to know in each of the chapters. We try and put that together in a study guide. And what I tried to do in week 2 on that last hour was review the study guide with everybody. So
Honestly, I don't think that
can I interrupt? I think going forward, I don't want, it's already 8:22, or excuse me, it's already, what is it, 3:22?
3:22.
So I think if we want to talk further about the exam, why don't you schedule a time to meet with me? Okay? Would that be acceptable?
Is there going to be changes going forward since the averages were so low, and that obviously reflects on the school and not the students?
I'm sorry, can you say that again, Michaela?
Are things going to change for the next exam? Because the average was so low, so that comes back and reflects on the school, not the individual students.
Okay, and what we're discussing, we're already talking about the second exam as a faculty, so let's wait. Dr. Lundy is our course lead, so I can't say there's going to be, that's a hard question to answer.
Okay.
Okay, hang on. Somebody's still trying to get in. Okay. Ayana,
Can
are
I
you
say
back?
something?
And who is speaking?
Teresa.
Hi, Teresa.
Hi. I wanted to say on a positive note, I know it must be hard for you guys to have exams thrown at you and not know what to teach, and I appreciate what you are doing for us.
Thanks.
You're welcome.
I appreciate that. Okay, so I'm going to go through, first thing I want to go through is the module or the, what am I trying to find here? Trying to find. Wow, that was a lot. Okay, I'm just trying to regroup here after that conversation. So just hang tight. I appreciate everybody's feedback. All right, we're going to jump to week 9 real quick because I want to introduce the vulnerable populations assignment. Okay, is anybody taking a look at this yet? Okay, this is an individualized assignment. It's not a group assignment. It's due in week 9. I like to present it in week 4. This assignment is 8% of your grade, so it's an important one. And I'd like for you to review the overview and the details, but basically this assignment is for you to pick we give a whole bunch of suggestions here to pick a vulnerable population in your community and do a research paper. It's actually a PowerPoint. We ask that you do a maximum of 10 slides, and that if you look at the rubric, this is what the rubric is at the bottom of week 9. Okay, but this is your assignment right here. Prepare, I want you to read it on your own, but prepare a PowerPoint presentation with 10 slides. Okay, and the first bullet is address, you can read it for yourself. First bullet is population, the 7 things would like you to address. Second bullet is the health risks, whatever population you decide in your community that you want to know more about. Okay, so here we also give a list of some resources. Okay, some national resources. So for example, if you were picking the homeless in your community, maybe you look at the state website or county website for statistics. Okay, maybe you for a different population, you call the health department, gather information. So this is not an assignment you start in week 8. Okay, so that's why I just wanted to present it to you in week 4. Okay, and so this is about your specific community. So please don't do an assignment that says the homeless population in the United States is such and such, or the teen pregnancy rate in the country is this, and talk about it's specific to your community. Okay, so here's a list of suggested vulnerable populations. Okay, does anybody have any questions about that?
And you said it was how much percentage?
It's in your syllabus, it's 8%, which is a pretty big chunk.
Yeah, on top of assignments and exams. Oh, Lord.
The second thing I wanted to bring up is your infectious diseases, okay? So this is, I don't know if Dr. Lundy has already talked to you guys about this yet. This is your second group project, so it's like a discussion. I think it's due in week 7. So right here. Okay, so this is the week 7 infectious disease. This is your second group project. So by the end of the week, if you could hang on. I'm going to be posting this handout in an announcement, okay? But it's in week 7. So if you want to read about it, it's in week 7 because that's when it's due. But I'm going to attach this handout as well. So somebody in your group, if you could just email me, okay? Each group will collectively decide on one infectious disease that's provided on this website, National Foundation for Infectious Diseases. So yesterday, my Tuesday group, I think 4 of them have already sent me an email. Somebody's doing SARS, somebody's doing COVID, somebody's doing another group is doing HIV. So pick an infectious disease and just let me know what you're doing. Okay, and that's the website. Okay, so if somebody in your group could email me or Dr. Lundy by Sunday, that'd be great. Okay, and here's the guidelines. Okay, name the infectious disease, what causes it, what are the symptoms, mode of transportation, and so on. Okay. Okay. And the specific guidelines of how to post it. And you can read through that. So I wanted to mention those 2 things before we got going. Does anybody have any questions about that?
No.
Okay, and then we are in week 4. So is anybody having issues accessing the hospice case study? Everybody, that's part of what's due this week. Okay, please access the case study through the module. Okay, not from the outside, right from the module, right from here. And then let's just take a look at our attestation questions for today. The 2 pairs.
Ms. Marvel,
Yes,
Professor Marvel,
yes.
do you get 2 tries on the hospice case study or just 1 try?
Just 1.
Just 1? Okay, so
Yeah.
the first
Yes.
one's your grade.
Yes, yes.
Okay, thank you.
You're welcome. So for next week, we've got 3 things. I like to go a week ahead with my students just so they know what's coming up. There's discussion question 2. There's another NCLEX assignment. Okay, and then next week for me, I will spend the second hour going through study guide number 2, and we're working on that. Hopefully you'll have it in the next couple of days.
Professor
Okay.
Marvel,
Yes.
can you tell us what the review questions are supposed to be on, like the topic that we have to pick?
I'm sorry, Rachel, be more specific. I don't understand your question.
The NCLEX review questions, that's through Saunders, right?
Yeah, it's right in here.
Yeah, I went to do it early, but
Just-
Dr. Lundy doesn't have hers open, so I can't see like what content I have to.
Okay, yeah, I don't have anything locked. So it's going to be right here. Is that what you want to know?
Yeah, that's exactly what I need to know. Thank you.
Yeah, you're welcome. Sure. Okay, I want to cover, let's see. start covering the content so we can get moving. Oh, shoot. Does anybody have any questions before I get started?
Did you already post what the group, are these the same groups for the last one?
Yeah, it's going to be the same groups. Yes.
Okay.
Yep. Yep. Okay. Okay, guys. When we think of what do you think? What's rural health? Anybody ever worked in rural health?
I actually do right now.
What do you do?
I work in the emergency department.
Okay.
Is that home care?
No, I work in the ER. Oh,
Of
you
a
mean
ru-
home? Hey, Dina.
Of a
Hi,
rural,
Teresa.
you mean you work in a rural hospital?
Yeah,
I do. Yeah.
Okay. And so do you have many roles?
Many roles.
Roles, like what department do you work in?
I work in the emergency department.
Okay.
In the
And
ER.
right. And so how big is your hospital?
Well, it's pretty sad right now with COVID and staffing shortage. We have one floor open right now with 37 beds. We have a 21 bed ER,
Mhm.
and we now have admitted patients out in the waiting room.
And how many areas do you serve?
I serve the ER.
No, I mean your hospital. It's rural, so how many communities do you serve?
Oh, I'm
Several
sorry.
counties.
I'm sorry. We actually serve 2 to 3 counties right now, depending on other hospitals.
Okay.
Yeah.
All right. What do you guys think the difference is between rural and urban? With regards
Well,
to,
I know from being at rural, we don't have access to specialties.
Right.
For instance, a heart attack, they need to be shipped out. I mean, we don't have the stuff there to do it. We don't have surgeons there. We don't have GI there. We don't have, I mean, so many things there.
That's exactly what I'm asking. Yep. So what are the barriers that rural populations may face with regards to healthcare? Who was just speaking about? I can only see a couple of people now that I
Oh, it's me, Teresa.
Teresa, right? Okay. So can you guys all see my screen?
Yes.
Yeah. Okay. So what are some barriers? What are some barriers that rural communities might face? Certainly access, right? Access to specialty care.
Yeah, and transportation.
Transportation is a big one.
Finances.
Yep, right. Access to specialized services. Finances, maybe lack of insurance. Maybe language barriers to different cultures, because rural communities may have a lot of migrant workers that are seasonal, different cultures. So lots of cultural barriers. Okay, so I'm just looking at the objectives. So access is an issue. We just talked about this, scarcity of health professionals. Poverty is very big in the rural communities. Limited access to services, lack of knowledge, social isolation, right? And migrant workers make up a lot of the rural community. Okay. Just going through the things I want to cover. We don't need to know the whole thing. Population characteristics and cultural considerations of rural community. Okay, we know there's a higher proportion of whites, higher than average number of younger and older residents, more likely to be married or widowed, fewer years of formal education, they tend to be poorer. And they also are at higher risk for being uninsured. Okay, we know that they have a much poorer perception of their overall health and functional status. Okay, much less likely to engage in preventative behavior. And this is big, this bullet right here, that rural community, you're going to see one of their biggest health challenges is chronic diseases. Okay, because they are less likely to engage in preventative behavior. Okay, so you're going to see more prevalent chronic diseases. Okay, tend to have poorer health and less likely to seek care. Okay, and Teresa already mentioned this, transportation, traveling time down to the cities or wherever to get help. Okay, the other thing with rural communities, a big issue in rural communities is lack of, one of the reasons that they don't seek health care for, let's say, domestic abuse, child abuse, substance abuse. Why is that? What happens in rural communities? They're so small. What happens? Everybody knows everybody, right? And so they don't want to start, usually the real touchy subjects like abuse and substance abuse and other kinds of abuse, they finally show up when it's in a crisis mode, right? Because they don't want everybody knowing about their business. Okay, and that's an important factor in the rural community. Okay. Women's health, including maternal and infant health, are a big concern in the rural community, right? There's higher infant and maternal morbidity rates. Okay, there's extreme variations in pregnancy outcomes. And here's a list of a few groups that are particularly at risk. Okay, you can read through that. Okay, health of the children that live in rural communities are higher risk. All right, urban kids, city kids are more likely to see a pediatrician when they're ill. Okay, where rural adults and kids are more likely to see a general practitioner versus a pediatrician. And what about the kids who work on farms? Okay, school nurses play a huge role in the rural community. Huge role. And then mental health is a big issue in the rural community. We just talked about delay seeking care for abusive situations. Depression, very high in the rural community, very high. High rate of poverty, isolation, and definitely an insufficient number of mental health services, domestic violence, and then the substance abuse. Lots of mental health issues, very prevalent in rural communities. And then what are some occupational and environmental health problems? Okay, well, there's definitely high-risk industries in the rural areas, specifically the forestry, mining, fishing, and agriculture. Please know this slide. No, slide number 12. Please know what the 4 high-risk industries are. Okay, there's also a lack of OSHA oversight with farming and ranching. Okay, common injuries are prevalent in the rural areas. Why? People don't wear seatbelts, farming equipment, exposure to chemicals, pesticide exposures on the farms. So those are your occupational and environmental health problems. We talked about this a little bit at the beginning. What are the barriers to care? Affordable, accessible, acceptable services. And then what about our attitudes? Right? Our attitudes, our beliefs, our values, our insights, our knowledge. when we're working with many different maybe working with many different cultures in the rural community. Teresa, would you agree with that?
Yes. Yeah, I'm here.
Yeah. Lots of different cultures in the rural community. Which could be a challenge for the community nurse who needs to design community health programs for whatever the needs are in that particular community. There may be a lot. Okay.
You have a lot of people moving to this area, especially from different areas of the country. So, I mean, it's so many different beliefs and religions and ways of life.
Where are you at, Teresa?
I'm in Tennessee.
Just curious. Thanks.
And I'm from the West, so it's even different for me to be here.
Yep. We mentioned some of these already. What are the main issues? What are some main issues for migrant health? Right? Lack of knowledge, inability to afford care, poverty, availability of services. I've already talked about a lot of these, but here's a list of them. Slide 17. Okay, so if you are a healthcare worker in a rural community working with lots of migrants, there's a lot of potential issues you may face. Lots. Okay. Case management in the rural community is very big because you need to organize. There's a lot going on in a rural community, so you are going to be the coordinators of care, identifying can you manage the care from Teresa's ER, or do you have to get them out into the cities or someplace where they have the specialty services? And that's what nursing case management does. Please know what we're in chapter 22, so please know what the goals and objectives are for Healthy People 2020 with regards to the rural communities, specifically the migrant workers. So you need to go back to your chapter in the book, pull up the box, the Healthy People 2020 box, and please know that. Okay, you guys know, my students do, but I'm sure Dr. Lundy's do as well. You need to understand the Healthy People 2020 goals and objectives for each chapter because they're different. Their goals and objectives are specifically related to the topic, the concept that the chapter's covering. Okay. The other thing I would highly suggest you review in each of the chapters is the prevention level boxes, primary, secondary, tertiary. They're in every chapter, okay? Specifically geared towards what the topic you're covering is. So those are two areas of the chapters that I would review. And as I told my group last week, or the last couple of weeks, the expectation is that you go to the PowerPoint, pull up the second slide, which is the objectives, and you should be able to articulate each of the objectives. That's what I expect you to get out of the chapter. Does that make sense? You should be able to get most of the information right from the PowerPoint. Okay, if it's not all in there, you may need to go into the book to gather the additional information you need. Okay. So that's chapter 22, but I want to show you something because we're not going to go over it today. I'm going to ask you to go over it on your own because I want to cover NCLEX test bank questions, but 24. So week 3. Okay. I sent you guys this in the announcements this week. Okay. instead of sending you 3 separate case studies that are in our instructor lesson plans, one of our teammates, Dr. Apple, put together a PowerPoint that combines, it's a combination of all 3 chapters for their case studies. So that's what I sent you this week. Has anybody taken a look at it yet? Okay, it's really, do you remember the first couple of weeks I sent you the individual case study from each chapter? This is combined now. It's awesome.
Oh, okay, wait, I know what you're talking about.
Yep. So I think maybe this is the first week I've sent the combined. No, weeks 3 and 4. Yeah. So no, last week and this week I've sent you combined. But weeks 1 and 2, you had all the individual chapters. Well, Dr. Apple put them together in one PowerPoint each week. It's great. So the other thing for Dr. Lundy's students, at least that I tell my students, is yes, you're responsible for the objectives. However, a lot of the exam knowledge, exam questions come from these case studies. Okay, we're big believers in these case studies because why? My students, tell me why I'm such a big believer in these case studies. What's the learning part of the case studies?
It has the rationale behind it.
The rationales are where you guys are going to learn a lot as well. Okay, so for example,
well, then the case studies is where you can apply the knowledge to see if you actually understand it.
Exactly. So chapter 22, here's your case study. Okay, here's your question. First question, here's your rationale. Okay, I don't need to go through these. You guys can go through them on your own. You're going to learn from these rationales. Okay, second question, the answer and the rationale. So don't blow off these case studies. Okay, they're as is, in my opinion, they're as important as looking at the objectives in the book, in the chapters. Okay, and I'm just going to jump ahead here. We're going to go to Power 23 right now, but I want to see. Here's week 4. When we get there, here's your combined PowerPoint. Okay, week 4 is chapters 29 and 30. Okay, so right here, week 4, chapter 29 and 30. These are the case studies that we get in our instructor lesson plans. Okay, so this is what we would be going over with you in class. Okay, so there's your case study. Here's your case study, same format. Here's the first question, there's your answer, and there's your rationale. So please, I implore you to look at these PowerPoints that we're sending you of the combined case studies. Case studies are just as important. Okay, anybody have any questions so far? Okay, this next chapter, this is a big chapter, okay? What we do in community nursing, most of what we do in community nursing is working with vulnerable populations, right? So this chapter's big. Okay, so there's 4 big types of vulnerable populations we're identifying: poverty, homelessness, teen pregnancy, and mental illness. And there's questions on exam 2 with regards to all 4 of these. Okay, so this is a chapter you need to know. You don't need to know everything about the chapter, but let's look at the objectives. That's what you need to know. Okay, you should be able to answer or articulate these objectives. Okay, so what influences poverty? Social, political, cultural, and environmental factors, right? Discuss the effects of poverty on health and well-being of individuals, families, and communities. Okay, you can read these objectives on your own, okay? But it goes through each of the 4 populations this chapter is discussing. Okay, so right here in your intro, 4 groups of people who represent members of vulnerable populations. Okay, the poor, the homeless, pregnant teens, and mentally ill. These 4 present complex nursing needs. Okay, this is important. Understand our own beliefs about these groups. What do we feel? What do you feel? What do you think when you drive down the street and you see a homeless camp somewhere? What are your beliefs about it? What are your beliefs, your values, your thoughts about pregnant teens, about the severely mentally ill, the poor? Those are things, if you're going to be in community nursing, you need to think about. Okay, with these groups, what are their healthcare needs? What are their barriers to care? And what are the essential services that they need? So this slide 5 is a really good one. Okay, it talks about attitudes, beliefs, and the media's impact about vulnerable groups. Right? What are the cultural attitudes? What's the what are the perspectives people have about these 4 groups? Right? What are the cultural assumptions people make? How does the media play into it? We have to consider our personal beliefs and attitudes and perceptions, right? Social, political, cultural, environmental factors all influence how society views these populations, right? And then here's a little cheat sheet for you guys. So slides 6, 7, 8, and 9 have to do with poverty. Okay, it's broken out. It's all split out into 4 different sections. Okay, so I'm not going to go through these. I want you to read through these, because again, I would much rather get through these PowerPoints and get to the questions, the NCLEX questions for practice. Do you guys agree?
Yes.
Okay. What's a definition of poverty? Okay, really good information. Poverty, how is health affected by poverty? What are the effects across the lifespan? You know, for kids, for adolescents, for adults, for older people. You know, if you are a part of long-term poverty, you know, generational poverty, how does that affect your life expectancy, your development of chronic diseases early? Okay. What are the effects of poverty? Think about women of childbearing age. Adolescent women, kids, older adults, and it's poverty is both urban and rural. Big issues in community health with regards to families in poverty. A lot of families in poverty. And a lot, you know, it's interesting because after we do this week, it ends up that a lot of students choose poverty to research in as their vulnerable population. So anyway, chapter, the next 3 slides are about homelessness, 10, 11, 12. Okay, understanding the concept of homelessness. What are the effects of homelessness on health? Substance abuse, mental illness, HIV, TB. And then who are the at-risk populations for homeless? Pregnant women, children, adolescents, older adults. I was telling my group yesterday, I mean, what do you guys do when you come to an intersection or come off a highway or in front of your grocery store and you have lots of homeless people out with signs, out, what are your beliefs about that? I was telling my group yesterday that outside my grocery store at home in Colorado, she's been there for probably 6 months. It's a young woman that has probably 3 kids under 5 years old. And they're always with her every time I go in or go to the grocery store. They're always with her in the heat of the summer and the cold of the winter. And I can't help but to buy an extra bag of groceries for her. I don't know if I assume it's legit, but I'm not going to take any chances that it isn't. So and think about the pandemic. I can tell you, working in the schools, that there's a whole lot more homeless families now than there were 2 years ago. A lot. From results from the pandemic, whether it's job loss or poverty, going into poverty, lots of families living out of their cars. Again, if you go into community nursing, public health nursing, this is what you're going to be working with. These really, really impacted populations. Families in poverty, homelessness, and then we get into teen pregnancies. I mean, what do you guys think about what are your beliefs? What do you think about that? I mean, in our district, it's such a big district. We have a school that houses all of our pregnant teens in high school. And so we offer prenatal services, childcare after they deliver, home visits.
You live in Colorado, don't you?
Mm-hmm.
That's really nice. Yeah, we don't have any of that stuff here. I know we have like daycares and stuff, but a lot of places don't provide that, which kind of like sucks, especially.
Well, and then and you think about the metro areas, the urban areas versus these smaller communities. So we were talking about with the last chapters, the lack of resources. Teen pregnancies 13 and 14, and then mental illness. Okay, mental illness in the United States is out of control and becoming worse in the last couple of years, especially with the younger population in the schools. Okay, the isolation, the remote work, the lack of social gatherings, it's big time. Okay, so slide 16 is an excellent example of primary, secondary, and tertiary with regards to these populations. Okay, so definitely have a look at slide 16 because at least my group, I don't know about Dr. Lundy's, but for the most part, my students did really, really well on the 5 or 6 prevention questions that were on the exam 1. So that told me that you already have a really good understanding of primary, secondary, and tertiary. As I'm doing reviews with students, there's only been a few students I've had to do 1 or 2 questions with levels of prevention. So, and remember, levels of prevention are ongoing, and they're heavily focused in the HESI. So you have to grasp levels of prevention in each chapter. You should be
What
able to,
chapter is that? I'm sorry.
we're in chapter 23 right now.
Okay, I was just making
But
sure. Thank you.
there are levels of prevention. You should be able to identify a primary, secondary, and tertiary level of prevention in all the chapters, whether it's faith communities, school nursing, hospice care. You have to be able to transition those levels of prevention into whatever topic you're covering. Does that make sense? So slide 16 is an excellent slide for levels of prevention with these vulnerable populations that we just talked about. Okay, and then the role of the nurse. Most important, what's our role as a nurse with these particular populations? First and foremost is try and create a trusting environment. And if you are working in the community, actually, if you're working in hospital, community nursing, acute care, Teresa in the ER, you're going to deal with all these vulnerable populations because eventually they're going to need healthcare in one way or the other, right? It might be a pediatric patient that's homeless. It might be a homeless person that gets frostbite. It might be a pregnant teen that goes into early labor. Does that make sense? So you are gonna, it doesn't matter what type of nursing you end up working in, you will interact with these populations, right? Are we in agreement on that, guys?
Yes.
Yeah. Yes.
Okay. All right. We're going to skip to 24. So 22 and 23, those are hard chapters. Okay, they are. Rural health is hard. Impacted vulnerable populations is hard. I mean, community nursing is hard. Think of what's going on in your own community right now. Think of what's going on in society right now. Think of what's going on in our communities. Hear about all the gun violence and all these, there's a lot going on in these communities. Okay, let's get to PowerPoint 24. I'm dying to get to these NCLEX questions because my group yesterday just absolutely loved going through these questions. Okay, this is another tough chapter, 24. Alcohol, tobacco, and other drug problems in the community. Go through your objectives. Here's our page of objectives. What are the attitudes about alcohol, abuse, tobacco, other drug problems? Right? What are the differences among major psychoactive categories, depressants, stimulants, marijuana, excuse me, hallucinogens, inhalants, right? What's our role, primary, secondary, tertiary, for alcohol, abuse, tobacco, and other drug problems? Right. And then what's the effect of substance abuse on, I don't know, let's say a family, a community? Big time questions. Okay. We know that alcohol, tobacco, and drug use right here in the first bullet is the #1 national problem. I was reading something today in the news that overdoses, fentanyl overdoses, are now the #1 cause of death in the country. Substance abuser is not only at risk for personal health problems, but they also may be a threat to the health and safety of themselves, their family members, maybe co-workers. We hear about workplace violence, other members of the community, ticking time bombs, right? In the scope of the okay, so ATOD, just for acronym purposes, is alcohol, tobacco, and other drug. Okay, so what's the scope of the problem? It causes multiple health problems for individuals. It's contributing, it's a snowball effect. Every culture has beliefs and attitudes towards alcohol, tobacco, and other drugs, right? And a lot of times we as a society categorize drugs as, good or bad. I mean, I think about marijuana. I live in a state that marijuana is legal. I don't have an opinion one way or the other, but I do know that there's a heck of a lot more high school kids smoking pot than there ever has been before. Does that make sense? Whether they get it, they're going to get it one way or another, but I don't know. Does it help to legalize? I don't know. We could talk for the next hour about the pros and cons, but I do live in a state that it's legal. And people joke with me all the time if I go back to Boston to visit my family, and my, family jokes, hey, can you bring some pot? I mean, Colorado, we were one of the first states. It's kind of like a joke. So anyway, lots to ponder. Definitions, we talked about substance abuse. What's the difference of substance abuse, drug dependence, withdrawal from drugs, addiction, alcoholism? And then this just goes through the rest of this. I'm going to let you read it on your own. Goes through the different kinds of drugs. Okay, your psychoactive drugs, and there's many. Okay, it gives you 3 bullets of what is the big picture of psychoactive drugs. And I'm sure every one of us in this group, every one of us, including me, have a family member, or maybe yourself, a family member, a coworker, a friend who's had an issue with substance abuse. It's tough. Working in the schools, especially with the kids of parents who have issues, it's tough. So anyway, an overview of psychoactive drugs. Okay, and then it breaks them down. Okay, so there's the overview. They're divided into categories according to their effect on the central nervous system. Okay, so there's your depressants, your stimulants, alcohol, tobacco is a drug, caffeine, and then it goes into illicit drugs, heroin. Heroin is the most often recreational used opioid. Cocaine, amphetamines, marijuana, hallucinogens, inhalants. What are some predisposing contributing factors? I don't know, is it hereditary? Is it a peer pressure? Is it the culture? Is it a physical addiction, a social addiction, social pressure? Okay, and then this slides 19, 20, and 21 go through each. It's actually really good. Read these. It has a whole slide on primary. What's primary? For example, promotion of healthy lifestyle and resiliency factors. Drug education. Secondary, screening. Our high school kids, drug testing, drug screening. Who's going to be at risk? Who's our high risk groups that we might need to screen? Okay, tertiary, they already have the issue. They already have the drug issue. Now we have to focus on detox or treatment, smoking cessation, support groups. And what's our role? Right? Our role with this, if we're a community nurse, we need to have a wealth of knowledge of what community resources are in our community that we're working in to help these people. And how do they mobilize them? Assuming that's a tertiary, but developing community prevention programs. Right? Get into the schools, talk to the younger kids about the effects of smoking, the effects of using drugs, the effects of using alcohol. I mean, we want community health is starting to make the pivot to really having primary prevention be at the top of our list. We've been so reactionary, right? And having to deal with it in a tertiary mode, right? Where the issues are already there. We really, really need to make that pivot in a much, in my opinion, a much quicker way to primary, which is prevention. Agreed? All right, that's 22, 23, 24. Give me your thoughts. Those are 3 hard chapters. This is a hard, yeah. What do you guys think? Anybody have any thoughts on those 3 chapters? Can you see how community nursing, public health nursing play a huge part in all these populations, and how many scenarios you may be faced with in the community?
Absolutely.
And remember, we're in community, we're taking care of people across the whole lifespan. We're taking care of babies and toddlers and adolescents and children and, special needs. Women have their issues, men have their issues, elderly. So you think of the whole group of the population we might be taking care of, and then you start thinking about what issues could be there. I mean, with community nursing, you really bring everything together. You bring everything you've learned together, right? Your med-surg skills, your ped skills, your OB skills, your leadership skills, right? It's a big, big, big umbrella. And then to boot, if you work in the rural community, where you have to be autonomous, you don't have a doctor that's on the floor with you. You may have a doctor that's 100 miles away that you're getting advice from. Okay, let's cover these 2 chapters in this week, and we'll kind of change the topic and make it a little bit more positive, and we'll talk about the faith community nurse. What do we think a faith community nurse is, and what do we think he or she does?
Works with like a religious community, possibly.
Mm-hmm.
Be like a missionary.
Mm-hmm. Okay, here's your objectives. This is one of our questions, our attestation questions, is the 2 models of faith nursing. And we'll go through it. We'll go through the 2 of them, but define faith community and holistic health promotion. Describe the roots of the healing ministries, right? As far as professional issues that come with it. All right. Faith community nurses have their own scope and standards of practice, just like school nurses do, just like hospice nurses do, just like home health nurses do. Faith community nurses also have their own standards of practice, right? What is the role of the faith community nurse, right? with the spiritual, how does he or she add the spiritual care for health promotion and disease prevention? Okay, describe the differences between spirituality and religiosity. Anybody know that? So religiosity is the religion. So let's, for example, my religion is Catholic. So religiosity for me is the Catholic religion. Others may be Lutheran, others may be evangelical, others may be Muslim, others may be Jewish. Okay, so the religion is your primary religion. Where when you think of spirituality, that's kind of like the big picture spirituality, kind of like your big picture perspective of religion. Does that make sense? All right, let's dive into this real quick. So parish nurses work in close relationships with individuals, families, and faith communities to establish programs, services that significantly affect health, healing, and wholeness. Okay, so so when I say parish nurses, I mean faith community nurses. They're interchangeable. Okay, so faith community nurses balance knowledge and skill in their role, and they facilitate their faith community to become a caring place. Parish nurses address universal health problems of individuals, families, groups of all ages. Okay, so I like this last bullet because parish nursing or faith-based nursing is a pretty big group of people. It's very, very common. Okay, parish nursing, faith nursing is gaining prominence as nurses reclaim their traditions of healing. I'm just reading the last bullet. Acknowledge the gaps in service delivery along with the rising of nursing centers. Okay. So definitions. What's a faith community? It's whatever your faith is. Okay. It's groups of people that gather wherever, churches, cathedrals, synagogues, mosques, and they acknowledge their faith. Okay. So faith community can be a number of things. Okay, so faith community nurses typically respond to health and wellness needs for populations of faith, right? And they usually work within the church or within the organization to fulfill the mission of the health ministry. In health ministry, what is that? These are kind of groups within the faith community, whatever the goals of the church are. So the health ministry may be visiting new parents. It may be doing grief counseling. It may be visiting hospice patients in the hospital or at home. Well, here's some examples right here. Visiting the homebound, providing meals for families, participating in prayer circles. It depends those are examples of health ministries. It depends what the goals of the faith organization are. Okay, we do need to know this. Okay, for the next exam, we need to know this. The difference between the congregational model and the institutional is super easy. Okay, we're on slide 5, super easy. All right, if the faith community nurse is working within the congregational model, it's simple. She's working only with the congregation, the members of that congregation. Okay, she's working towards the goals of whatever health ministries that congregation is set up. Read this last bullet, she's accountable to the congregation. Okay, however, let's assume that the health ministries have her focused on health and wellness, home visits. Okay, but let's assume that part of the faith community needs wound care needs IV care, needs PT, needs OT, needs whatever other services. Okay, the institutional model means that the faith community contracts out, so coordinates with outside services. All right, so they may coordinate with the hospital, they may coordinate with transportation, they may coordinate with the rec center, they may coordinate with what else? Hospitals, medical centers, long-term care places, educational places. Okay, so congregation, the faith nurse is focused on the congregation. Institutional model, he or she is coordinating services that some of their community may need with outside agencies. Okay, simple. We're not going to worry about historical perspectives. Okay, this is important. What is the difference? Why is faith-based community nursing singled out? Well, because it's the spiritual dimension that's central to the practice of parish nursing. Whatever that spiritual dimension is, whatever your faith is, that's what it adds. Okay? So depending on what your spirit, your religion is, it may be balance or how you perform your duties based on knowledge, skills of nursing, humanities, theology, whatever the history of your religion is, right? Parish nurses, faith community nurses emphasizes strengths of individuals, families, and communities. And this last one is a good one. Health, spiritual health. So regular health, spiritual health, and healing are considered an ongoing, interrelated, dynamic process. Okay, you guys with me?
What slide is that? 8?
That was 7.
7, thank you.
And it continues into number 8. Okay. Faith community nursing has separate scopes and standards of parish nursing practice. All right. So the health care that you provide, the health promotion is within the context of the client's values, beliefs, and faith practices. So for me, let's just assume I'm Catholic. If I want to educate myself and learn about, let's say, the Jewish faith, I can go work as a faith community nurse in a synagogue, right? I just need to make sure I have the education required. I understand the values, beliefs, and the practices, right? And the educational preparation for a parish nurse, believe it or not, it's a baccalaureate degree, a license, 3 to 5 years experience in professional nursing, evidence of mature faith. I mean, it's pretty educational focused. Okay, so the other thing that I want you to know is that with each different role of nurses, whether it's school nurse, faith nurse, occupational nurse, hospice nurse, home health nurse, there's 3 different categories that are going to come up with each one. One are professional issues. The next are ethical issues, potential ethical issues, potential professional issues. So I'm on slide 9 for professional issues. And the topic of the slide is issues in faith community practice. Okay, you can't be out in the community practicing without any oversight, just like you can't do it in the hospital. So you are going to have issues in the hospital with professional issues. Well, you're going to have issues in faith community nursing with regards to professional issues. How about ethical issues? Right? And then legal issues. Okay. So remember that. that all these different nursing roles we're talking about in the community all have to be able to address potential professional, ethical, and legal issues. And it's different. All those three are different for whatever, the legal issues for a faith community nurse may be different than the legal issues an occupational nurse may face or a school nurse may face. Okay. Faith nursing has, it's the only slide that has the, it has a fourth one of financial, but the rest of them don't. So I don't want to, I wouldn't worry about it. Don't worry about slide 12. I want to keep the focus on professional, ethical, and legal issues come with all these. And then please, we're in chapter 29. So the fact that it mentions Healthy People 2020 in the PowerPoint means that you need to go back to the chapter and look at the Healthy People 2020 box for faith communities and know what their goals and objectives are. Okay. And then here's a couple of functions of the possible functions of the faith community nurse. They may be doing personal health counseling. They may be doing health education. They may be a liaison, facilitator, providing pastoral care, services to the vulnerable population. It depends. What does it depend on? Whatever the goals, whatever the health ministry, the goals of the congregation, the goals of the church, the goals of the synagogue, the goals of the mosque, whatever they see the needs of the community are. Make sense? Okay, let's skip to our last chapter, which is 2 more different roles. And that is the nurse in home health and the nurse in hospice. Okay, so last week we covered school nursing, and then we just covered faith nursing. Now we're going to cover home health and hospice. It's one chapter. They're kind of used interchangeably. There's obviously some different characteristics with hospice, but they are talked about in the same chapter. And then in a couple of weeks, we'll talk about occupational nursing. Okay, so what does a home health nurse do? What does a hospice nurse do? Okay, compare different practice models. That's the other attestation question for this week. What are the 5 practice models? And we have a slide for those. Okay, so we identify the basic roles and responsibilities of home health, palliative care, and hospice nurses. Explain professional standards and educational requirements. Well, it's different, right? The educational professional standards scope of practice for a school nurse is different than a home health nurse, and is different for a faith community nurse. Don't worry about this don't worry about this 4th bullet, the Omaha system. If you want to read about it, that's fine, but for purposes of this, do not worry about it. Explain how nurses in home health, palliative care, and hospice use best practices. Right? Just because we're not in a hospital, we're out in the community doesn't mean we're not using best practices, evidence-based practice, and quality improvement strategies, right? That's in every area of nursing: school nursing, occupational nursing, home health nursing, public health nursing. We're always wanting hospital nursing, flight nursing, ER nursing. We're always using best practices, trying to use the best evidence we have to improve our practice, and always looking for quality improvement, right? All right, so one of the main points of this chapter is we know that patients would prefer to have as much of their healthcare provided in their home. Why?
Comfort.
Familiarity.
Could be a lack of transportation to get to like doctor's appointments and stuff.
Opportunity to work with the family as well. Teach them how to help care for their family members. Right? Home is a place where nurses have provided care for more than a century. And think of how much care we're now providing in the home than we did 10 years ago. You would have never thought to run IV medications in a home 10 years ago, right? Or to send people home with PICC lines, right? Or send people home with oxygen, it's incredible how much we're doing in the home. Home care gives clients and families a chance to receive health care in their usual home environment where they feel more comfortable. And it may be easier for them to learn how to make changes in their lifestyle that promote a healthier them in the home. And then, what about patients that are homebound? It may be the only kind of care they can get is home care. Okay. What's home care? Slide 4. Okay. Simple. Home care includes disease prevention, health promotion, and episodic illnesses related to services provided in their home. So I'm talking episodic illnesses. I don't know, maybe they've had a stroke and they're getting discharged home from a rehab center, and they still may need a little bit of PT or OT or speech, or that's what we mean when we say episodic illnesses, or their diabetes is out of control and they need home care to get them back on track of caring for themselves. Okay. And then obviously we've talked about this, that the home, based on research, suggests that the home is the optimum location for certain health and nursing services. I mean, who wouldn't like to get their care in their home? And we talked about this just a few minutes ago. Family caregiving, you have the opportunity to work with the family, to teach them procedures, teach them routines, teach them medication separations and, weekly dosing and all of that, right? Help, teach them to assist their family member who's needing care, right? Family caregiving, help them learn how to do their basic needs, hygiene, meal prep, medication, treatments. All right. And then working in the client's home also comes with challenges, right? We're definitely more autonomous when we're able to do that. But we're more autonomous. However, we need to be, competent in many different areas, right? Decision making, assessment in your ADPI. Not that you don't have to be in any setting, but the home setting is a little bit different than the hospital setting. You have more support around you. Home environment lacks many resources typically found in institutions. When working in a client's home, the nurse is a guest. And to be effective, you need to gain the trust of the family and establish a partnership with the family. And as with any other area of nursing, client safety is one of the biggest concerns, just like it is in other healthcare settings. We're not worrying about the history. Here's your 5 practice models of home care. Okay, you guys can read through the, well, actually, I just need you to know a 1-sentence summary about each one. So let's go through each one. 5 practice models in home care. Population-focused home care. Okay, directed towards the needs of specific groups of people. That's it. Population-focused. Whether it's the kids, the elderly, the special needs. It's a particular population that you're focusing on. Transitional care, hospital to home, rehab to home, home to hospital, assisted living to long-term, to nursing home to assisted living, transitional care. Okay. Home-based primary care. This is typically delivering primary care for people who have a hard time getting to a primary care clinic, maybe the homebound. Number 4, home health. Okay, home health, all you need to know is that home health are a combination of home health agencies that could be doing one of the 5. Okay. And then the last practice model is hospice. What's hospice? Palliative care of the very ill and dying. Okay. What is your goal in hospice? What is the practice model goal for hospice? Reducing distress from physical, emotional, and spiritual symptoms. And how about, I mean, what if you're a community nurse and you're doing hospice of a child? You know, very challenging. Scope and standards of practice, they're different for home care than they are for faith community. Okay. Direct care, indirect care. Nursing roles in home care. Here's all the different things you might be doing. So you can read through direct care. What would the scope and standards of practice look like for direct home care, indirect home care? Please read through 10 and 11. Okay. And then as with any other type of nursing, there's always going to be accountability and quality management. So please read through that. Home care actually is very strict with accountability and accreditation, right? And here's your legal, ethical, financial, professional, potentially aspects of home care. Okay. So that is 18, 19, and 20. And this is different from our last chapter, which was faith. The issues of legal, ethical, financial, professional, they're different for each group. Okay. Okay. So that's our, let's do real quick. Let's do our attestation, and then I'll stay on and do more questions because I know we only have 20 minutes left, but I'll stay on and do a few more questions. I can stay on after if you guys want and do a few more. So let's go to our attestation questions. And you can do this in Dr. Lundy's as well. I like to do this in class so that it gets done. Nobody has to worry about it because this is your check mark for attending class, your attestation. So the first question is somebody give a shout out to the answer. What's the difference between congregational and institutional faith-based nursing?
Congregational is within like a certain literal congregation. So it's one person reporting back to that parish, where institutional is bringing somebody in from the outside.
Yep, congregational is your only focus is the congregation. Where institutional, you're coordinating care, you're partnering with outside agencies to provide care to your faith community. Right? Did I say that easy? Congregational is only with the congregation. Institutional, you bring in the community. You can bring in community resources to help. And then second question is the 5 practice models. What were they?
Population focused home care, transitional, home-based, home health, hospice, and palliative care.
Excellent. Who offered that up?
Kim.
Thanks, Kim. Shout out to Kim. And you can put
Congregational.
what now?
Here's the definition of congregation.
What's the? I'm sorry. I'm only hearing a little bit of what you're saying. Does somebody need help with the first question?
Can you repeat those?
Can you repeat number 2, the answers, please? I only got the first 3.
Palliative, population focused, transitional, home-based, home health, and hospice. And those are on slide 8 of chapter 30.
Thank you.
Awesome. Okay, everybody hit submit. Okay.
Yeah, I can't type that fast. I'll just go back and do it myself. Thank you.
Somebody could, Kim, if you want, will you just put that in the chat?
Yes, I will.
Okay. All right, let's go and do some questions from week 3. Okay, so we're back to rural. This is rural, our 4 vulnerable populations, homeless. Where are they? Homeless, teen pregnancy, poverty. What's the 4th? Mental health. I'm having a brain freeze. What's our 4th? Mental illness, yes. Okay. Okay. Let's, where's my, you guys, I have the answers and I have the rationales. So somebody, okay, what's the answer to? Okay, what's number 1? Let's just go through it. What's number 1? I started reading the questions yesterday. You guys can read them on your own. Just read them and call out the answer. And then A. Yep, that's correct. Everybody understand that?
We're doing number 1.
Yep, number 1. It's saying you're in a rural community. You're not going to have an allergist, or you're less likely to have an allergist or a pediatrician or a pulmonologist.
Correct.
Right?
Yes.
We talked about that. Okay, number 2. Remember, we said this is rural.
D.
Nope.
Wait, are we still on number 1?
Nope, we're on number 2.
Okay.
C.
Why is it C?
Because it doesn't have a sufficient number of healthcare providers.
Often rural areas have a physician, a nurse practitioner, or a community nurse. That's it. Great. Number 3.
A.
Why?
Because it's
Because he
probably
probably
the
doesn't have
only
primary
place to
care,
have.
so he's just
Yeah.
gonna have to go somewhere that'll help him immediately.
Yep, that's exactly right. Good job. That's exactly right. Number 4.
Is it A?
A.
Why?
Because of
So it's a
the
huge risk for cancer, the pesticides.
Okay, it's long-term versus short-term. Here's your rationale. Chronic exposure to pesticides and chemicals may lead to cancer. Memory loss, the other ones, memory loss, skin rashes, and headaches are all potential side effects of short-term exposure. Okay, number 5. See, this is where I think you guys get the most learning, is going through NCLEX questions like this. That's
Yeah,
my opinion.
I
What?
really like, I said I really like this, like when we go through like
Exactly. This
I'm
is
like
what
a visual and auditory learner. So like
exactly.
yeah.
I'd rather do this for 2 hours.
Yeah, same.
Okay, go ahead.
Next one, C.
Yeah, why?
Because it's a farm worker, and that sounds like issues with pesticide poisoning.
Exactly. Yep. 6. Oops, sorry.
Is it A?
A.
Why?
Because the question says he's Hispanic, and a lot of the times, like in rural areas, I doubt that they have like the technology like the hospital I work at has with like the translators and stuff. If he's in a rural area, he's more than likely like not very great at English.
Yep.
So I feel like he wouldn't have like he would.
That's exactly right.
Yeah.
That's
You know
that's
what I'm trying to say.
I know
Sorry.
exactly. That's a perfect answer. That's exactly right.
Yeah, and A is the only answer that has cultural competence in it, like she said, and it said Hispanic.
Yep. So these are good. These are good questions. These are good NCLEX style questions. Number 7.
B.
C.
C.
Why
Or
is
C.
Why is it C?
Because migrant, he's moving place to place to earn money, and that's performing seasonal agricultural work.
It's temporary. Exactly. Yep. Okay. 8.
I think it's B.
What did you say?
I said I think it's B.
B as in boy or D as in dog?
As in boy.
I say D.
I say dog.
D,
Why?
because they're worried about not getting paid. They won't think they'll get paid for that day for money.
That's exactly right. Yep. Number 9.
C.
D.
Why?
Because they can't afford other workers, so they're
So usually,
taking
yeah.
workers.
Exactly. All right, let's do one more. And then we'll do 10 questions in week 4. One of the things that I think I'm going to do, maybe next week sometime, is do a review, an extra review for class, an extra review or 2, and just simply go through questions, because this particular bank of questions for this week has 70 questions. The one for week 4 has like 48 questions. So I just think that this is how we learn, a lot of how we learn. So I may do an extra review next week to just do these kind of questions.
Our next one is 2 weeks. I'm sorry, I just take it 1 week at a time. Our next exam.
It's in 2 weeks, but next
Okay,
week we
thanks.
have to prepare for it.
I was just making sure I had my dates.
I
right,
know.
sorry.
Can you imagine? We're already talking about exam 2. Actually, that's good. That's good. All right, number 10. Let's do number 10, and then we'll move to the next week.
B.
Okay, what did you say?
B is in boy.
Yep. Why?
Well, because you're speaking directly to the patient. You're calling them by name. You're kind of breaking the ice and making them comfortable. At the same time being very respectful to them. So they'll appreciate that.
Exactly right.
And probably open up more.
It's that establishing trust, right? Because the one thing in community is people aren't very trusting. You have to establish a relationship, right? They're just not. And one of the things we cover down the road in community is the visits, the home visits, the voluntary versus involuntary visits. The voluntary visits, who's going to call the health department for a voluntary visit? Well, maybe new parents and, all the fun, fuzzy stuff, visits. But what about the involuntary visits, the court-ordered visits? Okay. When you're knocking, that they don't want to see you. The patient's diagnosed with TB in the community. It requires a home visit. So we'll talk about that down the road. But okay, let's go to week 4. We'll do 10 questions here. Okay, so remember, this is faith, community, and home health. So number 1. You guys, number 1 should be easy.
A.
Yes, thank you. Why?
Because it says the difference between parish nursing and all other nursings, and parish nursing is within a congregation or a church.
Right. Everybody gets that, right? That's what we just talked about. Remember, faith community nursing is the same as parish nursing. Same thing. Okay, number 2.
I'm not sure about that one.
Anybody have a guess on number 2? How many people do we still have left in here?
Is it
well, think of what's the question? What's the question describing? They have healthy meals to homebound people. So what would that be? Would that be a ministry? That would be a ministry within their congregation.
B.
Right, right. Do everybody understand that?
Did you say A?
No,
Or
B.
Or B?
Health
Okay, I
min-
thought it was B.
Yeah, health ministries are those activities and programs in faith communities that organize around health and healing to promote wellness and health across the lifespan. Whether
Okay,
that's, go ahead.
No, I
Whether
was
that-
just saying thank you for reading that.
Yeah. Okay, number 3.
B.
Answer's A. Okay.
Oh, A.
People, yeah. So think
Okay,
about
that
it.
makes
What is
sense.
the faith community hopefully do? It brings in all your beliefs and traditions, right? To help with, if we're looking at holistic care, belief and traditions to help with coping. Let me read you the rationale. Persons who encounter assaults with physical and emotional illness and brokenness, and who are able to call upon their faith beliefs and religious traditions, are able to increase coping skills and realize spiritual growth even through adversity. Does that help?
Yes.
Okay, number 4.
C.
What'd you say?
C.
Nope. Oh,
B.
wait. C. Did somebody say C? Sorry.
4C.
Yeah. 4C. Yes. 5. We understand why. 4C,
Yeah.
right? Okay, number 5.
C.
Correct. The spiritual dimension of healthcare is central to the practice of parish nursing. Right? Okay, 6. This was in our PowerPoint.
C.
Correct. Health, spiritual health, and healing are all considered parts of an ongoing dynamic process. Okay? 7.
I think it's C.
Did she say C?
Mm-hmm.
D.
D as in dog.
Yeah.
Which of the following statements suggest that faith community nursing is a nationally recognized specialty of nursing? Well, it's their individualized scope and standards of faith community practice. Right?
Okay, I see.
8.
B.
B as in boy.
Is it B?
Yeah.
Yeah, B as in boy.
Yeah. They're not immune from responsibility or accountability. They have scope. You have a scope of care, standards of care, scope of practice to practice within, right? That's why there's professional issues, financial issues, ethical issues, and what's the other one? Legal issues, right? In every kind of community nursing, whatever role you're going to be in. It's going to be different issues that are going to come up. Okay. All right, number 9.
A.
A as an
Yep.
apple.
Yep, that's in your PowerPoint, right? Okay, number 10. Last one for now. This should be a no-brainer.
D.
D.
D is in dog, right? Why?
Because they shared within a strictest
That's HIPAA.
confidence, and
It's
it is
HIPAA.
HIPAA. And
Yeah, it's confidentiality, right? Okay.
Yes.
Okay. So, was that helpful to go over those 20 questions?
yes,
Okay. So, okay. So I'm done. Feel free to get off. However, I think, like I said, I'm going to talk to Dr. Lundy in the next couple of days. What I think I want to do next week is still use the second hour of lecture to review the study guide and talk about strategies for studying for the exam. That's what I want to do. If you guys are all good with that, if you want to go a different direction, you let me know. And then I would like to try and schedule another review, 2-hour review or something, whatever. 1 or 2 of them, I don't care. Whatever I can do to support you guys and just focus on all these questions. I have, like I said, I have 70 something and 40 something. So what's that? Almost 110 questions. I'd rather do these questions than Kahoots. Sorry. I just would. I mean, I'm happy to send you the Kahoots and you guys can do them on your own, but I don't know. I think that these test bank questions are professionally, they're NCLEX preparation questions. So what do you guys think about that plan?
I think it's great. I think the Kahoots are super helpful too. So.
Yeah. But I only have so much time. And,
right.
You know, I'd rather you guys can do the Kahoots on your own. It doesn't need to be a competition. I mean, it's fun to do that, but.
Yeah, I mean, that's fine. We can do them on our own too. That's perfect. I just wanted to make sure we're still accessing those. So I think those help me too.
Yeah, I sent my group both week 3 and week 4 Kahoots, right, guys? Should have.
I don't think, I mean, I'm in Dr. Lundy's class and I don't know, she hasn't sent us those yet, but I'm assuming she will at some point.
My group, you guys are getting them, right?
Yes.
Anybody?
Yes.
Yeah.
Yeah.
So that's kind of self-study. Self. So, and again, I'll talk to Dr. Lundy about doing a review session next week. But I'm going to spend the second hour of our lecture next week doing the study guide, specifically the study guide. Okay.
Okay, thank you.
Will that help?
Yes.
Has this been helpful?
Mm-hmm.
Yes.
Yes.
Okay. All right. Well, nice to meet everybody in Dr. Lundy's class. I enjoyed having you guys. Thanks for all your interactions, your feedback, everything. I'll stay on if anybody has any questions, and have a good rest of the week.
You too. Thank you.
Thank you.
You're welcome.
Thank you.
You're welcome.
Professor Marvel, can I talk to you for a minute?
Yeah. Who's that, Allie?
Yeah,
I'm waiting to hear back from you to see if you want to meet on Sunday.
I never got that. I've been refreshing my inbox.
I sent it to you. Wait, I have
Where?
a little note that says Allie ? Sunday.
I work on the weekends because it's the only time I can work. I work for the local ER, so I have to do 12-hour shifts.
Okay. I have, no, I sent you a message about Friday.
Yes,
at,
I have clinicals. Yeah, I have clinicals from 7 to 5. I was gonna see if you're available sometime tomorrow. And if it's early, like I wake up really early. I wake up at 5:30 due to a 2-year-old. So I wake up early.
Yeah.
So
I could do something. Yeah. I have to do, hang on, let me look at my phone to see what my at-risk meeting schedule is tomorrow. Tomorrow's the 3rd?
Yes.
Okay, so I have, let's start there. Thursday. Just bear with me.
That's okay.
My Thursday. I have more pieces of paper going right now. It is silly. Hang on. Tomorrow. I think I start at, oh my gosh, I know where I can find it. It's on my calendar. Hang on. Just hang tight, okay?
And there's no worries.
Okay, I just need to get out to my email. Oops. Am I still sharing?
Oh, I don't think so.
Okay.
If so, I'm on my phone, so I can only see me and you right now.
All right, no worries. All right, let me get to my calendar. Tomorrow, Thursday. All right, I start at risk meetings at 3:00.
Eastern Standard.
No, that's Mountain Time. Hang on. 8 a.m. Hang on. I got to figure out this time thing. So 8 ahead 7 is 3. So I start at 8 a.m. with my first meeting. So do you want to meet at like 7:30?
Absolutely, that will work.
You want to do that?
Yeah.
Okay.
And
so
it's because I don't really want to go over, I mean, I would like to go over the exam, but
you want to talk about
the case study.
You want to talk about the case study?
Yeah.
Okay. All right. Hang on. I'm going to get you back again. Oh, do you want to go over the exam or just talk about the case study?
I just want to talk about the case study.
Let's do that. Go. Let's just do
Okay.
Can you do it? I'll just do it now?
Yeah, I can do it right now.
Go.
I was just because you mentioned in the comment about how our group wasn't put together, and I was really confused about how we were supposed to put it together, if we were supposed to submit it individually. And then I know one of my group members, I don't know if there's anybody else on here right now because I don't really want to throw her under the bus.
It's just oh wait, we're still recording. Hang on. So let me stop the recording.